Good morning, everyone. Happy New Year. I wish you all success and a prosperous New Year, successful and a prosperous New Year. This New Year will be discussing the first topic of this New Year will be DIC, which is also called disseminated intravascular coagulation. So, we'll be discussing some brief points on DIC and all the conditions associated with DIC and some pathogenesis, some pathophysiology, and some diagnostic algorithms and some scoring systems, and also about the treatment. So, what are the conditions associated with DIC? So, DIC is associated with infections, sepsis syndromes with gram-positive and gram-negative bacteria, and viral infections like dengue and Ebola, and other fungal and rickettsial or malaria. And also, by trauma or tissue damage can be due to head injury or crush or penetrating injury, can be heat stroke, burns, pancreatitis, fat embolism. Also in malignancy, and we seen in solid tumors, acute leukemias, especially AML M3 and AML is acute myeloid leukemia, and obstetric complications like abruptio placenta, amniotic fluid embolism, eclampsia, preeclampsia, retained dead fetus, and vascular disorders like giant hemangiomas and other vascular malformations and large aortic aneurysms, and severe toxic reactions like toxic shock syndrome, snake and spider bites, and severe immunologic reactions, and acute hemolytic transfusion reactions and transplant rejection. So these are all the causes associated can lead to DIC. So they might not, also they can lead to DIC. So these all the causes are listed. So what is the frequency of DIC in selected disease states? So in gram-negative sepsis is 30 to 50%, and in severe trauma and systemic inflammation it's the highest, which is 70% up to 70%, and metastasized tumors to 50%, and epithelial placenta and amniotic fluid up to 50%, and preeclampsia to 7%, and giant hemangiomas up to 25%. So according to the percentage of the disease states, so what exactly happens in the DIC? So according to this flowchart, we'll go briefly. Increased level of tissue factor will be causing widespread and uncontrolled activation of coagulation. So which platelet activation and inefficiency of coagulation inhibitors will cause fibrin deposition in the vasculature, and exaggerated fibrinogen degradation and impaired fibrinolysis will cause concomitant activation of the inflammatory process, which will lead to consumption of platelets and clotting factors, and hypoxia, hemodynamic and metabolic derangements will cause organ dysfunction, and clotting factors will lead to life-threatening hemorrhage, consumption of platelets and clotting factors. So this is how this is initiated. So we should be knowing this. And DIC is often seen as a complication in snake bites. So it's very important to know. So activate factors 10 and 5, and activates prothrombin even in the absence of calcium, and activates protein C, and inhibits platelet aggregation because of the presence of arginine glycine aspartic containing peptides in Russell fiber venom, and releases fibrinopeptide, degrades fibrinogen, and damages endothelial cells, which lead to bleeding, tissue ischemia, and edema. So this is mainly in hemotoxic snake bites, which is usually a viperine bite. It's common in India. So hemotoxic snake bites does all these activation of all these uh, coagulation factors and other tissue factors can lead to disseminated intravascular coagulation. So by definition, DIC is acquired syndrome characterized by the intravascular activation of coagulation with the loss of localization arising from different causes. So this is by definition. So I'll repeat once again. This DIC is an acquired syndrome characterized by the intravascular activation of coagulation with loss of localization arising from different causes. So there might be different causes, but the ultimate thing is the intravascular activation of coagulation is the mainstay, and it can originate from and cause damage to the microvasculature, which is sufficiently severe, can produce organ dysfunction. So the incidence, several retrospective studies suggest that DIC is relatively uncommon entity, but most prevalent etiologic factor was infection. But another study of more than 50% of cases was in obstetric patients, where there is amniotic fluid embolism and eclampsia, preeclampsia, and the dead fetus, retaining dead fetus, been listed as the most common causes in obstetric patients. And a Japanese study was found that 45% of DIC cases were associated with malignancy. So this is the incidence, and this is a very important scoring algorithm in case of DIC. If you are suspecting DIC, so you should be looking around all these components, which will see platelet count and fibrin markers. So how do we score the platelet count? If it is more than 1 lakh, if you count it as 0, it is less than 1 lakh, you give a score of 1, and if it is less than 50,000, if you give a score of 2. And the level of fibrin markers, what all fibrin markers do we see in DIC, which is D dimer fibrin degradation products. So if there is no increase in D dimer or fibrin degradation products, you give a score of 0. Increased but less than 5 times upper limit of normal, you give a score of 2, and a strong increase more than 5 times, will give a score of 3. The next, you'll see the prothrombin time. If it is less than 3 seconds, you give a score of 0. If it is more than 3 seconds but less than 6 seconds, you give a score of 1. If it is more than 6 seconds, you give a score of 2. So, and the fibrinogen level, if it is more than 1 grams per liter, then you give a score of 0, and less than 1 gram, you give a score of 1. So if the score is more than or equal to 5, compatible to over DIC, will repeat the score daily. If it is less than 5, it is suggestive for a non-over DIC. Will repeat in the next 1 to 2 days. So how do you differentiate a DIC from other disorders which show a similar presentation? So DIC usually see consumption of platelets, so definitely the platelet count will be low. There will be an increased PT and prothrombin time, and activated partial thromboplastin time will be increased, and there will be a decreased fibrinogen. So there will be consumption of fibrin, and there will be a consumption of platelets. So there will be both will be decreased, and the PT and APTT will increase. So in thrombotic thrombocytopenic purpura, as we have discussed before, there will be also consumption of platelets, but the PT and APTT will be normal, and the fibrinogen will also be normal. And as well, a hemolytic uremic syndrome also has a reduced platelet count, but the PT, APTT, and fibrinogen will be normal. And idiopathic thrombocytopenic purpura, definitely there will be consumption of platelets because of the antibodies formed against the platelets. So definitely there will be massive platelet destruction, and the PT will increase, and APTT will also the PT will be normal, and the APTT and fibrinogen will also be normal in ITP. And in cirrhosis, there will be definitely the platelet count will also decrease, and PT and APTT will increase, and fibrinogen can be normal or decreased. And in heparin overdose, the platelet count will be normal, PT can increase, and APDT will also increase, but fibrinogen will be normal. In carbondin, normal platelet count with increased PT and APDT, and fibrinogen will also be normal. In heparin induced thrombocytopenia, it's also called as HIT, the platelet count will decrease because due to the consumption of platelets and destruction, and can be normal or increased prothrombin time, and APDT will definitely increase, and fibrinogen is normal. So this is how we differentiate by the following parameters, with platelet count, prothrombin time, partial thromboplastin time, and fibrinogen. So by all these components, we can differentiate the other bleeding disorders. So you should keep this in mind. So the other differential diagnosis can be in severe liver disease, which is more common, and primary fibrinogenolysis or pathologic fibrinolysis, which is rare. So the differential diagnosis between DIC and liver disease is challenging. Lab features include thrombocytopenia due to platelet sequestration and portal hypertension, hypersplenism, and decreased synthesis of coagulation factors and anticoagulants, and elevated level of fibrin degradation products due to reduced hepatic clearance. So in liver failure, the liver is one of the sites where the coagulation factors are sensitized. So definitely there will be a decreased synthesis of coagulation factors and anticoagulants, and there will be elevated level of fibrin degradation products due to reduced hepatic clearance. However, in contrast, DIC, the parameters on the liver disease do not change rapidly, and other findings include presence of portal hypertension or other clinical or laboratory evidence of underlying disease. So platelet count is usually normal. The D dimer level should be normal or minimally elevated. So protamine sulfate tests will be negative. Thus, a routine coagulation test should be able to distinguish DIC from primary fibrinogen. So what clinical manifestations do we see? Clinical manifestations are related to the magnitude of the imbalance of the hemostasis. So the more the consumption of the clotting factors, and the more the the reduction of the platelets can have the more damage. So it depends upon the magnitude of the imbalance of hemostasis. So the more the imbalance of hemostasis, the more complication and the more organ damage you see in the DIC due to the underlying disease. The most common findings are bleeding ranging from oozing from the venipuncture sites, petechiae, ecchymosis, to severe hemorrhage from the gastrointestinal tract, lung, and into the CNS. So usually the patients who are already hospitalized, or who are getting treatment in an intensive care setting, will definitely have intravenous catheters, and so definitely there will be primary bleeding from the or definite oozing of the blood from the venipuncture sites, and over the body there will be petechiae and ecchymosis development, can lead to severe hemorrhage from the GI tract, and from the lungs you can see in the form of hemoptysis, or bleeding into the CNS, can causing hemorrhagic strokes. So these are the most common findings usually which complicate the patient who is in DIC. So in chronic DIC, the bleeding symptoms are restricted to skin or to the mucosal surfaces. So can see petechiae, ecchymosis, these kind of things, but you won't see any GI bleeding or any hemoptysis or any hemorrhagic stroke kind of manifestations. So hemodynamic complications and shock are common in acute DIC. So you should that keep in mind. So chronic DIC, what is chronic DIC? Low grade compensated DIC can occur in clinical situations, including giant hemangiomas, metastatic carcinomas, or a dead fetus syndrome. And plasma levels of fibrin degradation products or D-dimers are elevated, and ABDT, PT, and fibrinogen and platelet counts are usually normal. So this is these findings are seen in chronic DIC. So you should keep this in mind. So, how do you treat the morbidity and mortality associated with DIC are primarily related to the underlying disease, so rather than the complication. So, definitely the underlying disease, if it is well managed, then it can directly prevent DIC and can save the patient to develop complications. So, definitely the mortality and morbidity depends upon the underlying disease the patient is having. If the patient is having any malignancy, is undergoing treatment, but it is continuously relapsing, so he has a very high chance of mortality from DIC because the underlying disease is not controlled. And so likewise in patients who are having obstetric complications, so if the patient is not getting proper treatment from conditions like eclampsia, preeclampsia within time, or if the patient is retaining a dead fetus, so definitely the patient is very vulnerable to develop DIC. So definitely these patients should be managed in the first place for the underlying disease, then to prevent the complications such as DIC. Management of the hemorrhagic symptoms, administration of fresh frozen plasma or platelet concentrates is indicated for patients with active bleeding or at high risk of bleeding, which is with invasive procedures or after chemotherapy. So fresh frozen plasma and platelet concentrates should be administered in hemorrhagic if the patient has developed hemorrhagic symptoms. And PT, if it is less than 1.5 times, is a good indicator of severity of the clotting factor consumption. So fresh frozen plasma is indicated in such cases. 1 unit of FFP increases most coagulation factors by 30% in an adult without DIC. And low levels of fibrinogen less than 100 milligrams per deciliter or brisk hyperfibrinolysis which will require infusion of cryoprecipitate. Uh, so plasma cryoprecipitate is a plasma fraction enriched for fibrinogen factor 8 and a von Willebrand's factor. So infusion of cryoprecipitate in patients with low level of fibrinogen less than 100 milligrams per deciliter will definitely increase the levels of fibrinogen in such patients. And the replacement of 10 units of cryoprecipitate for every 2 to 3 units of FFP is sufficient, and platelet concentrate at a dose of 1 to 2 units per 10 kg body weight are sufficient for most cases. And replacement of coagulation of fibrinolysis inhibitors, a low dose continuous infusion of heparin 5 to 10 units per kg per hour is effective in patients with low grade DIC associated with solid tumor, uh, acute promyelocytic leukemia, or in a setting with recognized thrombosis. So coming to the algorithm, how to evaluate DIC. If there is a clinical suspicion of DIC or any underlying condition known to be associated with DIC, or there is low or decreasing platelet count or a global clotting assays, use the DIC scoring algorithm which I have discussed before. You score the platelets, the platelet count, the fibrin degradation products, the PT, and so on. So definitely, if the score is less than 5, there is no DIC. Consider repeating the test for after 1 to 2 days. And if the score is more than 5, it is compatible with DIC. So we will treat the underlying condition. So if there is active bleeding or there is no need to undergo invasive procedure, the platelet transfusion with total platelet count with 30 to 50,000 and plasma or the factor concentrate administration with PT with less than 3 seconds prolonged and fibrinogen more than 1.5 grams per liter. So and the vitamin K supplementation if needed, and antifibrinolytic treatment is in case of excessive hyperfibrinolysis. And there is no major bleeding or thrombosis. If there is no major bleeding of thrombosis, prophylactic low molecular weight heparin can be given. And over thromboembolism and organ failure related to clot formation, therapeutic anticoagulant treatment is indicated. So the recent emerging therapies, a high dose of antithrombin replacement therapy has shown no effect on mortality, and the role of protein C in ameliorating the mortality in sepsis has been demonstrated, and the clinical trial with recombinant soluble thrombomodulin in patients with sepsis and DIC is ongoing. So laboratory diagnosis of DIC has been the mainstay in the diagnosis. So the plasma fibrinogen level, PTT and PT, platelet count and FDP and D dimer have been the major diagnostic tools in diagnosing disseminated intravascular coagulation. The fibrinogen level of 200 milligrams per deciliter in normal or healthy subjects may represent a significant decrease whose baseline was 800 milligrams per deciliter owing to an acute phase changes. The best test for diagnosing DIC is the D-dimer assay. So definitely keep in mind, can be asked as an MCQ. So the best test in diagnosing DIC is the D-dimer assay. And the semi-quantitative method is sensitive, and the D-dimer values of more than 2000 nanogram per ml is diagnostic. So we should keep in mind. So D-dimer assay and D-dimer values of more than 2000 nanograms per milliliter is diagnostic. So summarizing, excessive thrombin generation triggered by the tissue factor overexpression related to the underlying disease process, platelet activation, and defective natural anticoagulant pathways including tissue factor pathway inhibitor, antithrombin and protein C, and insufficient fibrin degradation due to impaired fibrinolysis or exaggerated fibrin and fibrinogen degradation, and concomitant activation of the inflammatory process, and diagnosis is on the ISTH score, and treatment of the underlying disease, symptomatic treatment, and low molecular weight heparin prophylaxis in sepsis, platelet and coagulation factors replacement as indicated. A selective use of factor 7A or fibrinolytic inhibitors is critical. So some on summarizing, so these are the salient features, how the process takes place, of the process of DIC takes place. Uh, so that's it for today, students. If you have any doubts, please leave a comment, and definitely if you want to discuss any other topic, please let me know. If you want to discuss any topic, please let me know, especially in blood disorders, infections, any topic you want to discuss. I'm just waiting for your comments in live chat. Please let me know if there is any doubt, or if you want to discuss any topic in the next class. I just see names and roll numbers of the students who are in the class. I don't see any comments. Please comment if you want to discuss any topic, if you have any doubts. Okay, then I hope you all are preparing well for the exam. If you have any doubts, please let me know. I'll be there in the Department of General Medicine. My name is Dr. Ramchandra Prasad. So please let me know if there are any doubts or if you want to discuss any topic in particular. So that's it for today. Thank you so much and happy